Good morning, everybody. We'll go ahead and get started here. My name is John Hickman. I'm one of the current chief residents, and it is my distinct pleasure to welcome you to the start of the Department of Medicine's Grand Round Series for 2021. On behalf of the department, Drs. Frazier, Costco, Spencer, my co-chiefs, and our amazing administrative staff, I want to thank you for being here today. We have an exciting lineup of speakers this year, including highly anticipated talks from Dr. Tate Shanafelt from Stanford, the director of the CDC, Dr. Rochelle Walensky, and many, many more. We will have a mixture of virtual and hybrid talks throughout the year, with some speakers finally joining us in person, COVID allowing. So please check out the calendar on the Department of Medicine's website for upcoming talks, including their location, as they may vary throughout the year. We're also very excited to announce the creation of a Department of Medicine YouTube channel, which will host videos from all of our upcoming talks, as well as lectures from the last couple of years. I am particularly excited for the next 4 weeks, as we will highlight 8 amazing senior residents from our training program. Today, we'll start off with some introductions, followed by 2 talks with time for questions for either speaker at the very end. Starting off, we have Dr. Rachel Cohen. Dr. Cohen received a BA from Indiana University before attending Tulane, where she achieved both her MD and Master of Science degree in pharmacology before joining us at WashU both in the primary care track and the teaching physician's pathway. Dr. Cohen has done extensive work looking at social determinants of health and racial justice, and is actively involved with research in our own primary care clinic on the effect of providing blood pressure cuffs to our patients. Her talk today will center on the obesity epidemic as a social determinant of health. And then next, we will have Dr. Abbye Clark. Dr. Clark began her studies at the University of South Carolina, where she stayed for medical school, before joining us at WashU for internship and residency. She has received national acclaim for her work on rural-urban disparities in appropriate UTI antibiotic practice, for which she won first place in resident research at the state chapter of the American College of Physicians. Her talk today will focus on current issues involving PrEP, stemming from her work at our local county STI clinic. Dr. Cohen, take it away.
Hi, all. I'm going to share my screen. All right. Okay. Hi, everybody. My name is Rachel Cohen. I'm a PGY3 here in the primary care track at WashU. Today, I'm going to talk about how obesity is both a result of social determinants of health and its own social determinant of health. I have no disclosures. These are my learning objectives. We're going to identify the various social determinants of health that lead to obesity, recognize and address these social determinants of health in a primary care setting, describe how obesity is its own social determinant of health, give examples of how the stigma physicians hold against patients with obesity affect patient care, and develop strategies to mitigate your own bias as a physician. First, we're going to start off with a case. This is a 54-year-old female with a past medical history of hypertension and diabetes. They come to your office to establish care. Her main complaint is lower back pain. Her back pain is a constant achy pain that sometimes radiates down her left leg. She has no alarm symptoms. During your thorough review of systems, she admits to you that she has gained 40 pounds in the last year. Her current BMI is 45. She takes 650 milligrams of Tylenol 2 times a day without much relief. She wants to know what else she can do to help the pain. What do you tell her? And we're going to get back to this case towards the end of my talk. So the first thing I wanted to do was go over a definition for social determinants of health. Medical care is estimated only to represent 10 to 20% of modifiable factors for healthy outcomes for a patient. So the other 80 to 90% are social determinants of health. This is the CDC definition of social determinants of health. They are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. We're going to talk about the 5 different categories of social determinants of health that are broken down by the CDC. The first 2 categories that we'll talk about is economic stability and education access and quality. In a study done by Booth et al. In 2017, they looked at obesity and its relationship with income and obesity and its relationship with education. They found that having a college education appeared to protect against morbid obesity, and having a household income greater than $75,000 a year appeared to protect against morbid obesity as well. The next category that we'll talk about is social and community context. And this category of social determinants of health describes the social aspect that people live in day to day. So this study that we'll go through is Suglia et al. In 2016. And this talks about obesity and crime. So in an adjusted analysis in this study, individuals who perceived their neighborhoods as unsafe had a BMI that was 2.81 points higher than those who perceived their neighborhoods as safe. And this is a flow chart that the authors of this paper created to show the flow of how we get from neighborhood, socioeconomic status, crime to obesity. The next one we'll talk about is neighborhood and built environment, and this is the physical space that people live in that that is a social determinant of health. So there's 3 things that we'll talk about that represent neighborhood and built environment. First is green spaces. Green spaces are the recreational areas that people can live and work and play in a community. So in a Milona et al. Study in 2019, patients with obesity were less likely to live in neighborhoods with the highest accessibility to green space areas compared to their normal weight counterparts. The second thing we'll talk about is food deserts. Food deserts are geographic areas where residents' access to affordable, healthy food options, especially fruits and vegetables, is restricted or non-existent due to the absence of grocery stores within a convenient traveling distance. In this study, with other factors remaining constant, food deserts increased an individual's odds of being obese by about 30%. And then for food swamps, which are areas with high density of establishments of fast food and junk food relative to the healthier food, Cooksey Stowers et al. Showed that even controlling for food desert effects, food swamps have a positive, statistically significant effect on adult obesity rates. So what do we do? How do we address this in clinic? The first thing that we can do in clinic is utilize the food boxes that the nurses hand out. So nursing staff has an algorithm that they use to find people who are food insecure or people who don't have enough food on a day-to-day basis. And if they finish the survey and it shows that they're food insecure, then they will get food boxes with healthy foods from the CO, or for those of you who don't know, that's the primary care clinic for our residency. Additionally, at least before COVID, there was a food truck outside of the Biddle House of Phinia that came on Wednesday afternoons and was basically a mobile grocery store on wheels with healthy, reduced price produce. That's another good idea for patients. And then, getting creative about how to work out, telling your patients, you can use videos on YouTube, workout videos, or you can take the stairs inside the complex if they feel uncomfortable walking around their neighborhood. Other resources like 211 United Way, this is a really awesome thing that allows people to type in whatever kind of resource they need. Let's say they need housing, and it comes up with a list of resources in your area. Then there's also behavioral health therapy and new ideas, like maybe one of the residents wants to create a workout group with some of the co-patients. There's always room for new ideas. So we talked about 4 of the 5 categories of social determinants of health. What about healthcare access and quality? Before we turn to that, I'm going to go back to the definition of social determinants of health. Again, these are the conditions in the environments where people are born, live, learn, etc., that affect a wide range of health functioning and quality of life outcomes and risks. And this is really how we get to obesity as its own social determinant of health. Obesity is definitely a condition, and it's arguably an environment, as this is the environment that people go through the world with. So we're going to switch gears now and talk about how obesity is a personal environment that affects healthcare access and quality, and therefore acts as its own social determinant of health. So the first thing that we'll do to get there, and honestly, this is the driver of obesity as its own social determinant of health, is the stigma that people and physicians hold against patients with obesity. And these categories up here, these descriptions are all shown in studies to be correlated to the stigma that people hold against patients with obesity. Things like lazy and lack self-discipline, lack willpower, annoying, dishonest. And then interestingly enough, in the very beginning of obesity stigma research, they thought that maybe there was some research that showed that maybe the stigma mitigated the obesity epidemic. And we know that that is, not true, because the obesity rates would be going down, not up, if there was a benefit or if there was an incentive for weight loss with the stigma. As we know, stigma is still pretty high. So stigma, the stigma that people hold against people with obesity makes for a lot of bad things to happen to these patients, including increased binge eating, eating more in general, avoidance of exercise, depression, increased pathophysiology associated with obesity, delay of preventative care. Patients who are obese are less likely to seek out preventative care or primary care because they're afraid to be judged, reluctance to talk about health issues, and then, of course, what we're going to talk about today, healthcare disparities. So what about physicians? That's the general public, though we as physicians are better than this, right? The answer, unfortunately, is no. The first study that we're going to look at is this Hebel and Zhu 2001 study about physicians and obesity stigma. This table in front of you shows the 13 indices that they used to survey physicians with primary care physicians about their patients with obesity. This study found that with 122 physicians surveyed, patients who suffer from obesity, they viewed patients who suffered from obesity significantly more negative on 12 of the 13 of these. So some of them that were more noteworthy are extent to which this patient would annoy me, a significant decrease in personal desire I had to help this patient, a significant decrease in belief that the patient would follow my advice. And additionally, they found that physicians indicated that they would spend significantly less time with patients with obesity. So what happens with physicians and their stigma? So this leads to they perceive patients with obesity as less adherent to meds. They also demonstrate lower levels of emotional rapport with patients with obesity. And then 67% of practitioners in one study did not believe that 10% weight reduction would be enough to improve health. As are indicated by the NIH guidelines, 10% weight reduction is shown to positively benefit a patient's health overall. And we are taught that usually as physicians. However, 67% of practitioners in this study did not believe that piece of studied advice. So what? So we have this stigma. Does it change patient outcomes? And the answer is yes. So one thing that we get is changed perceived outcomes. There's two studies that I'm going to go over here. One is spinal surgeons who significantly overestimated the risk of adverse events in patients who are obese following a posterior lumbar fusion, which is something that a lot of our patients with back pain will receive. And then more pertinent to our internal medicine lives is this study with critical care doctors. So they basically got a bunch of different clinical vignettes that some of them, the patients at hand had obesity, some of them didn't, some of them had lung cancer, some of them didn't, but all of them had Apache scores of 25, which means that their estimated hospital mortality or they had identical severities rather. So the Apache score indicates the amount of severity that a case has in the ICU or the intensive care unit. Critical care doctors ranked estimated hospital mortality significantly higher in these patients with obesity. And maybe more worrisome was that these physicians were more likely to recommend limiting care with curative intent in patients with obesity. And this is scary, right? Because their Apache scores, their severity scores are all the same. And yet, if the patients have obesity, then the physicians with these clinical vignettes were more likely to recommend limiting care with curative intent. We also spend less time with patients with obesity. In one study, it was 6 to 7 less minutes per visit. PCPs were more likely to rate the encounter as a waste of time with patients with obesity. And they also indicated that they would spend 28% less time with the patients compared to those who evaluated normal weight patients. And then very much pertinent to us is changes in primary care. Patients with obesity are less likely to receive smoking cessation medications. They're less likely to get cancer screening like mammograms, pap smears, colonoscopies. And then also interesting, mothers are less likely to be taught how to breastfeed if they are obese. So what can you do about these stigmas and these changes in cares as a primary care doctor specifically, or as a doctor in general? First, your response to a patient's complaint, your first response to a patient's complaint should never be, you need to lose weight. You need to gain trust first. There's no handbook that says you must bring up weight loss on the first visit. But am I failing to my patient if I don't talk to them about weight loss? I say no. If you push someone away by ignoring their complaints or alienating them, then they are definitely not going to listen to you or better their health, and then you are in a sense failing them. Be aware of your own biases and challenge them is another thing we can do here. If you catch yourself thinking negatively about an obese patient or blaming them for their weight gain, stop. Think about why you thought that. Are you frustrated with the person or with the situation? What are the societal pressures that play into this negative thought? Is it a true thought? Is it actually that simple? What else could be at fault besides the patient? Do this every time you have a negative thought or you catch yourself saying something out loud. Also, As you might have noticed, I have been through this talk trying my best to say patients with obesity and not obese patients. And by adding the with, you're indicating that obesity is a disease and not a personality trait or flaw. It seems like a small thing, but these little things do add up. Learn about the body positivity movement, build awareness to anti-fat bias. So, you can also do this by increasing your social media bandwidth. I do this by following plus size models on Instagram. It seems like a little thing, but it takes away the stigma of people with obesity as being gross or unattractive by showing people who are overweight and are attractive. And that is one way that I can mitigate my own bias. And remember, BMI is biased in and of itself. BMI was originally popularized in a study in 1972 by Keyes et al. That looked at only men and mostly white men, mostly ages 49 to 59, with a few that were younger. So let's get back to our case. So this is the 54-year-old woman with a past medical history of hypertension and diabetes who comes to your office to establish care, has this complaint of lower back pain. She's had weight gain. She takes 650 milligrams of Tylenol 2 times a day without much relief. She wants to know what else you can do to help the pain. What do you tell her? So what do you tell her? So first of all, it might not be appropriate to bring up weight loss at all because this is the first visit. I would max out the Tylenol and try some other adjuvants like gabapentin and low back exercises and PT. Schedule an appointment for her to come back in a short time, like 4 to 6 weeks. At the next visit, then approach the topic of weight loss. But how? We do so with humility and empathy like we do every other patient. I like to say something like, I'm sorry that we've tried all these things, these therapies, and your back still hurts. I know you know this, so I'm not going to harp on it. But as your doctor, I would not be doing my job if I didn't at least mention weight loss. I know weight loss is so hard. It's something or you can say I watch others struggle with all the time. We are obviously going to try other things for your back, but I also wanted to mention that weight loss may help as well. In fact, only even losing 5 to 10% of your weight has been shown to help some of the pain and other problems with back, with health. And then you pause. And then you can say, I do have resources for weight loss. Is this something you would be interested in talking about further? And that's it. You've done your job there. If she says no, then you let it go and you try to work on other aspects of the pain instead of the weight loss. Just as if somebody wasn't ready to quit smoking, you would move on and try other things. And so this is basically the end of my talk. I wanted to thank you guys all for letting me speak on this topic. I'm passionate about health equity, and I feel like this topic is extremely important in that realm, especially given the large number of our patients who suffer from obesity. And as I demonstrated, these patients are not receiving equitable care. I hope this talk has given you guys some insight into the effects of obesity stigma and will help you navigate your own bias. I'd like to thank the following people: Dr. Susan Reeds, who was my mentor in this and runs the obesity weight loss clinic here at WashU, Dr. Schmidt, Dr. Costco, Dr. Frazier, the chiefs, my co-residents, my family, and my friends who tuned in today. Thanks, guys.
Dr. Cohen, thank you so much. Fantastic job. All right, and we will again come back to questions for both speakers at the very end. In the meantime, we have Dr. Clark, so you can go ahead and take over screen sharing ability. And Dr. Cohen, you can stop your sharing.
How do I do that?
There should be the green button there where you share.
I see it.
Yeah,
thank you.
Perfect. All right.
All right. Hi, everyone. And And thank you for that introduction. It is great to be here this morning and to give an overview of the current issues in PrEP, or also known as HIV pre-exposure prophylaxis. I look forward to going into a fellowship in infectious disease, and I have been a part of the Global Health Scholars Pathway here throughout residency. Through that, my research project has been in PrEP delivery in the St. Louis County Health Department, and through that experience, this topic has become very important to me. All right, so to move on to the outline, it will first be an introduction to PrEP and identifying its associated definitions. Then we will look at the present usage and identify the challenges, specifically the disparities that exist within PrEP. Lastly, we will look at how PrEP delivery overall can be improved and how especially this could help alleviate the current inequities that are found within PrEP and its management. All right, so first to start with the background. For an overview, PrEP is currently in the form of an oral medication daily to prevent new HIV infection, which currently does carry a grade A recommendation for those at high risk. These can be different, very different categories that include a known seropositive partner. This could be a sex partner or a drug, injection drug partner, inconsistent condom use, any recent diagnosis of any other STI, having shared drug paraphernalia, or a history in the past of needing post-exposure prophylaxis for varied reasons. Currently, the status of PrEP is two different forms of an oral medication that is a combination of intracytidine and tenofovir. The older version of tenofovir is also known as TDF, and it is traditionally classically associated with GI upset at first, but then decreased bone density and also renal toxicity at times. The newer version, also known as TAF, is actually not as more associated with the bone or kidney problems, but actually more metabolic effects overall and sometimes with weight gain. TDF was approved in 2012, so it has been around for a little while now and is more widely known as its branded name, Truvada, while TAF has only been approved approximately 2 years ago, and a lot of people actually know it more as Descovy. Interestingly, something to take note to is that TDF is for both men and women currently as a approved indication, while TAF is actually just currently for men who have sex with men, or MSM, and transgendered women, not currently cisgendered women. So to move on to the current standard of care right now, it includes checking for current infection of HIV as well as hepatitis B, given the nature of Truvada being actually a treatment for hepatitis B as well as checking for kidney function and pregnancy tests. If your patient is MSM, you do test for other STIs more frequently, every 3 months, at all 3 sites that could be infected, oral, rectal, or genital. Otherwise, you perform the STI testing only every 6 months. And then specifically, if you are prescribing TAF, you would continue to monitor their lipid profiles. So to continue with the standard of care, something interesting and an important part of PrEP management is actually something called the comprehensive prevention programs that provide needed information to the patients, on this being kind of a different type of therapy. It needs to include how the meds are designed to work, the importance of adherence, encouragement and advice on safer sex and injection drug practices, pregnancy planning, as well as needed like reevaluations of if that individual continues to be in a high risk category and does need to continue being on PrEP. So the studies behind PrEP, there are a lot of them, and they are important to be aware of. And the takeaway is that over time, they have shown efficacy in HIV infection reduction in all of the relevant populations, specifically with TDF, the older version of PrEP. Moving on to this graph, you can see that the studies over time have very clearly shown a direct correlation between medication adherence as well as and the effectiveness of the regimen, as you can see here, with X being the detectable drug levels found in study subjects corresponding to the effectiveness of the actual regimen. And you can see there's a fairly straight line going up. So to move on to the present, we previously discussed the categories of individuals that are at higher risk, but now we'll look at who actually does make up this over 1 million people that PrEP is indicated for. The most predominant population are men who have sex with men, with a quarter though being heterosexual and a tenth of those being people who inject drugs. Half are African American, with the rest being fairly split between Latinos and Caucasians. Keeping in mind though that overall the distribution in the United States is that African Americans only make up 13% of the population, Latinos 18%, and Caucasians 61%. So here are the distribution of people who are actually receiving PrEP. And you can see there is substantially more uptake in Caucasians than others, which is actually extremely discordant with the actual known percentages of new HIV diagnoses, where you can see 44% were African American, and with a specific breakdown to MSM African Americans were at 26%, and Latino MSM were at 22%. Also keeping in mind separately that heterosexual cisgender women were also 16% of the new diagnoses at the same time in 2019. So another way to look at this striking disparity is in the comparison. You can see here in this graphic where only 1% of the indicated African American patients were on PrEP, with only 3% of indicated Latino patients. Similarly, only 2% of the indicated heterosexual women were prescribed PrEP all at the same time in 2016. So, we've kind of seen, that there are a lot of different disparities affecting different populations. Now is a time to kind of think about what are some of the factors that are behind these disparities. There are obviously a lot of things you can think about. Structural and financial barriers are important, like transportation difficulties for some patients, and also affording health services. Being insured just by itself has been shown to make you up to 4 times more likely to be on PrEP. Factors continue to include racism, stigma, as well as a person's own perception of HIV risk. And, if you think about it, a provider's own perception as well. Systemically, there can also be, kind of similarly, a pretty profound, sometimes discomfort in primary care to even begin the conversation of if PrEP is indicated and specifically in starting the PrEP regimen if it is needed. There is also medical distrust from patients. Specifically, there is documentation of some patients seeing like social media claims from different law firms about concern for PrEP safety, which is also damaging to discussions and the initiation of PrEP. So there is data that specifically suggests that minority MSM are actually less likely to have knowledge of PrEP or to even have discussions about it with their providers. However, there is actually no difference in the willingness of wanting to use PrEP between all MSM. It is very similar overall. But in the end, Caucasian MSM, that population, the PrEP use in that group is actually double that of others. So another key piece is actually representation in research for these medications. Some are probably familiar with their Discover trial. It has been a large non-inferiority study for comparing PAF to TDF, the older version. But almost all of the research participants were cisgender men. There were no cisgendered women. There were few African Americans, but there were no people who inject drugs that were involved. One specific concern with this is actually the lack of inclusion in the primary data. One specific concern with this lack of inclusion is that primary data shows that TAF may actually be safer in pregnancy, but as mentioned, cisgendered women were not actually, included in the initial study, and so the results for them will actually be several years in coming out. So next you can see from this diagram that the complexity of the care system for PrEP itself is another really large challenge to obtaining and staying on PrEP for patients. Patients must be assessed as high risk, be in one of those categories. They must be educated on how PrEP works, navigate the finances of how to obtain it, get the pertinent labs, and then be prescribed PrEP, which ideally would all happen within 1 week. And that's not to mention all of the follow-ups, that are required afterward. So there are many different models that have been enacted over time to try to figure out the best way to assess and deliver PrEP to patients. Kind of starting off first is, the pro of the clinic model is that patients can get everything in one location, but the con is that individual clinics can have a tough time ensuring all the needed resources are available. The collaboration model is a little bit different in that it's good for outreach, using the community organizations, and it's better for harder to engage patients. However, sometimes it's hard to kind of keep all of the, the balls in the air at once with, the different partners agreements trying to work together. And sometimes it can be harder for patients with the transportation difficulties. So one of the newer approaches that has been coming out is actually a home-based model where transportation is less of an issue, but it can actually lead to difficulties more so with the lab specimens and the quality and able to be analyzed after it's delivered to lab. So to see a type of collaboration model in a real world example, this is some past data that has been collected about the co-management done between the St. Louis County Health Department Sexual Health Clinic with a local pharmacy. As you can see, specifically the collaboration model can, is able to better care for more racial and sexual minorities, but there can be, a pretty significant drop off as the locations are added on, and causes increasing complexity for some patients. And there also is noted a continued disparity in the African American patients being less contactable by the pharmacy than the white patients were. So the cost of PrEP itself is another hurdle patients must also overcome. It begins, at the branch point of, does a patient have insurance or not? If they don't have insurance, there are a couple different, things out there for them to help with affording PrEP. One can be the manufacturer's medication assistance program. If someone, is 500% below the federal poverty level. Another one that is available at any income level is the Ready Set PrEP program. That's via the U.S. Health Department and is available if someone does have a current negative HIV test, as well as a PrEP prescription from a provider. Something else to note is that fortunately, as of last year, the TDF version of PrEP was released as a generic, and the good news about that is that like one pill is $1 a day. So moving on to kind of like what is coming up in PrEP in the future, and kind of ways that we can continue to change PrEP for the better. One way is new routes of PrEP treatment. The one that probably people have heard of more than others is cabotegravir. It's actually likely to be approved later this year and is an injectable that will typically be given over 2 months, where they really only have to come in really like pretty spaced out, with actually less labs that are needed. So there are 2 other medications that are also in the works a little bit behind that. One is Determinant, and it is a vaginal ring monthly. And then is Islatravir, which is currently still in the pill form, but there is plans to potentially make an implant instead. So this is a kind of busy slide, but the CDC guidelines are actually changing soon for PrEP. And their current draft for public comment, there's actually a new recommendation that all sexually active patients know about PrEP. And with this, hopefully, this will vastly increase the awareness overall of PrEP as a treatment option for patients, and hopefully in that vein, decrease the stigma as well. There is also a new recommendation to actually spread out the creatinine kidney monitoring to annually for persons who are younger and who have had a normal kidney function and thus save money overall. There will also be new official guidance on same-day PrEP initiation. This is where having the assessment and the prescription of PrEP the same day to hopefully help lower those drops in care retention that we saw earlier. There will be new official guidance on on-demand PrEP, which is the dosing regimen used more intermittently for some patients. It works better. It's where you take 2 pills before sex daily, and then 1 24 hours and 48 hours after the last sex. There will be new guidance on telehealth appointments and management, as well as on the cabotegravir. They will be issuing new guidance on that as well, because it will be coming out fairly soon. So a huge step that just actually came out in increasing PrEP access to patients actually recently just happened with the federal government now requiring insurance to cover PrEP without cost sharing to patients. This will include the medication, the associated labs, and the visits to clinic. As well as, like I mentioned earlier, just last year, the generic came out, which overall will be $30 for a month for the older version TDF. So as we talked about, there's a myriad of opportunities and potential solutions for the current state of inequities that we've gone over in PrEP. These solutions can be seen in better delivery models for PrEP to adapt and meet the patient's individual needs, because every single patient you meet is different and needs different things from you in the healthcare system. The solutions can be seen in more primary care office involvement and beginning the conversation with patients. They can be seen in continued work with insurance and the cost of medication when the patients are uninsured. And also, where it really all begins is needed more inclusion in the medication research to really include all the affected populations for this. So I really would just like to thank my mentors, Dr. Hillary Reno, Dr. Joe Cherubi, Dr. Kayleen Matar, as well as Dr. Costco, Dr. Frazier, the chiefs, and all of my co-residents for their help with this and just residency in general. And then just my last slides would be my references.
All right, thank you so much. And Dr. Cohen as well. Those are both just fantastic talks. I think we have a little time for questions here. And I know we've got at least one here in the chat to start off with. So the first one is for Dr. Cohen. Any thoughts about how to approach the quote unquote healthy obese patient? That is a patient with obesity with no chronic conditions and normal labs. How do social determinants of health affect your approach with this patient?
So I would say, sorry, I was gonna let Abbye turn off hers. I would say that, one, I would probably not address the issue until I had a good rapport with the patient. And then I really would let the patient lead. So if they have concerns about their weight, then I would be happy to delve into that with them. If they don't say anything and they don't have any complaints, then I probably wouldn't say anything at all. It's not, if they're healthy, then it kind of defeats the purpose of saying anything. As for social determinants of health, how those play into that, I think, in the same ways that they play into people who have health issues and who have obesity. But I don't think that that would necessarily change the conversation.
Great, thank you. The next question for Dr. Clark. Let's say you have a new resident who's just graduating training and going out to start primary care. What recommendations or resources would you provide for them if they have an interest in starting PrEP in a new practice where it's not already established?
I would, the first thing that comes to mind is actually the CDC website is an amazing resource for just PrEP information overall and the things that are needed to really talk to a patient about PrEP and the things that are needed to continue monitoring. I would say also reach out to like the local infectious disease department. If you had any questions, they are always more than willing to be advocates for PrEP and for any questions that you have in starting any kind of like PrEP management in your practice.
All right. Well, again, I want to thank both of you for fantastic talks. I hate how there's no applause anymore, that we don't have a big group of people here, but here's a lot of applause for you guys. You did so fantastic. So thank you so much for sharing your work and for being with us today. We really appreciate it.
Thank you.
That's it for us today. Sorry for everybody. I know there was a few technical difficulties, some people having trouble getting in, so I'm glad that all of you were able to. We'll try to sort those out for next week. Please come back and join us. We've got 2 more amazing senior residents giving some talks, and you won't want to miss it. If you have any ideas or interest in certain speakers that you'd like to see come present for Grand Rounds, we still do have a couple openings, more towards the winter and spring of next year. But if so, I'd love to hear about it. So please email me, johnbhickman@worcester.edu. Thank you again for being here.